Thank you for joining iMeet.
We can reference later.
This meeting is now being recorded.
Thanks to everyone who just called in. We're just waiting for a couple more people to join, and then we'll get started. We are using slides today, so if you're able to connect to iMeet at your computer in addition to with your phone, that would be excellent. So a couple of people who have joined the call, your phone number is appearing, not necessarily your name, so it just has to deal with how you joined. And then there's a couple of names that I don't 100% recognize. So if you're on the call, if you could just briefly say your name and the organization that you're from, that would be really helpful as we get to the discussion portion of this webinar. So I have Dolores from the March of Dimes, and I have Amy Smith from Mid-Hudson. I have Cleo Rydesky and Abby Smith from UPMC. And then anybody who I didn't just mention, let me know.
Steve Ratcliffe.
Hi.
And this is Cindy Barter, and I'm on with Julianne Lupo from Hunterdon.
Yes, this is Amy. I also have Tamia Tozer, who is our new research assistant.
Hi, Jess. This is Paige from the March of Dimes.
Hey, Paige.
Hi, this is Beth Anderson from Williamsport.
Hey, this is Naomi Flock from NHRMC.
As more people join in, we might try to grab their names as we go. We'll just be interrupted by the beep. So I would say for sake of time, we'll go ahead and get started. So Amy, if you want to move the slide. Today's webinar is going to focus on depression screening, and it's going to be facilitated by Dr. Amy Smith from Mid-Hudson. I just wanted to provide a couple quick network updates for everyone on the call. Our spring meeting is Friday, April 7th, in Lancaster, Pennsylvania. So if you have yet to register through the network's link or to reserve your room at the Eden Resort, I highly recommend doing it ASAP. The deadline was Monday. I know the hotel said they were busy that weekend. They may still be reserving rooms with a room rate, but the sooner you do that, the better. In addition to that, in the most version of the newsletter, put out a request to contact the network if you had any interest in participating in scholarly activities. So specifically, the NAPCRG PBRN conference, NAPCRG annual meeting, or the FMEC. Those are some of the larger meetings that the network typically attends. So just trying to engage anybody who wants to be a part of that scholarly activity, send an email. And then in addition to that, we are completing our network site dates before the April meeting. So if you've yet to schedule that with your network coordinator, please do so. All right, so moving on to depression. Amy, if you want to go to the next slide and start, it's all yours.
Can you hear me?
Yes.
Okay. Our objectives are to review the implicit depression data so far and to mainly to discuss the depression screening techniques at the different sites. Who's screening for depression, how the sites are administering the PHQ-2 or the PHQ-9, and what the expectations at each site are for documentation. So, as we all know, depression symptoms occur in 20 to 40% of women during pregnancy or postpartum. Depression has a peripartum occurrence of 40%. The recommended workflow for ICC is to have PHQ-2 administered, and that can be implemented by the front desk staff, the person rooming the patient, or the provider. If it's negative, at the next visit. If it's positive, they should have a PHQ-9 and a safety assessment. If they're both negative, you would screen at the next visit. If either is positive, they should be further assessment, treatment, and or a referral, and a reassessment at the next visit. In REDCap, if the results of the PHQ-2 are negative, there would be nothing. Is that better? If the results of the PHQ-2 are negative, there would be nothing further. If it's positive, 2 more questions open up. The PHQ-9 score and the maternal safety screen. If the PHQ-9 is less than 10, or if it wasn't done, there's nothing further. If it was positive, you're supposed to document whether an intervention was in place or provided. For the maternal safety screen, if the mother has no thoughts of harming herself or others, or if it was not done, you would stop. And if she has thoughts of harming herself, there should be an assessment for safety and appropriate triage. These are our current numbers for everybody reporting into REDCap. We're going to go through these a little bit slower on the next couple of slides. But this was given out to everybody with the last update of your site data as well. Okay, this is just for Mid-Hudson. I wanted to break it down a little bit better. So at Mid-Hudson, we had 393 visits that did not have a PHQ-9 done. We had 1,834 that were, the PHQ-2 was negative, and 89 that were positive. Of those 89, I'm sorry, the arrows got a little squished over, 26 had a positive PHQ-9, of which 22 had an intervention in place or provided, and 2 did not. If everyone could mute their phone, somebody is making a lot of clicking noises. Thank you. With the previous slide, part of this column, the risk column, includes anyone who had a positive PHQ-2 and then did not have a PHQ-9, as well as anyone who had a positive PHQ-9. So all of the PHQ not done 40 and the PHQ positive 26 are included in this risk column. If they had a negative PHQ-9, they're removed from this risk column. And this is over total well-child visits, not well-child visits where mom was present. This gives a little bit further breakdown on some of the sites that had some discrepancies in their data. Not discrepancies so much as they're not going with the rest of the network. Lancaster has a very high percentage of missing PHQ-2s, and then University of Pennsylvania has a very high percentage of yes positives for PHQ-9s, which is one of the reasons we're doing this review today, to see how things are working at each site. We do have data quality rules built into REDCap that are automatic. They are fairly complex and are available for everyone to review. But basically, if you have answered a question for the PHQ-9 or the safety screen, it will automatically change the results of the 2-item screen if there's a discrepancy.
Yes.
Right. Mario and Dr. and Elizabeth Anderson, if you can mute your phones, it's still bringing in noise, and I only know because it's telling me that you're the ones talking. So, sorry. Thanks. All right, go ahead, Amy. Sorry to interrupt.
No, actually, we're just about to the point where I wanted everybody else to start talking. So we'd like to go around and for everybody, if we could run through who at your site is screening for depression, how you're administering the PHQ-2 or the PHQ-9, and how you're documenting each of those. Don't know if we want to just run through the list, Jess, or start at the top. Is there anybody from Lancaster here?
Let's pause for 1 second and see if anybody has any questions, because I think that for people unlike me and Amy who look at this data every day, it may have been a bit much. So any questions on our depression data and what Amy had presented that we could clarify? Okay, no questions. Sure, Amy, I think it would be great if we kind of went through the list of sites that are collecting data and answering these types of questions, and then anybody on the line who's not collecting data can have the opportunity to present as well, because we have some of those.
Great. I would love to jump in and talk about Lancaster. We have, up until really the current time where we're making a significant change, have relied exclusively on clinicians to do all of ICC, i.e. The questionnaire or the questions are not posed by our MAs or LPNs. They are triggered and done exclusively by the residents and faculty. So on the one hand, we have one of the higher positive PHQ rates, and these have been administered verbally, and I think our rate is around 18%. But that's where, when we've taken a good look at this, we've known for a while that it's been a focus of a number of us over the past month that we have some real flaws in that when you ask that verbally, middle of well child care, it's a positive 2, our clinicians then kind of take, instead of finding the PHQ-9 and administering it, they jump in and do a quick depression inventory, and 90% of the time when they feel that there's some type of depression present, they're doing something about it at the visit. That's the good news. The bad news is that approximately 70% of the time the 9 at least has not been recorded in REDCap. We have learned from a lot of anecdotal feedback. People say they've done it, but they just haven't put it in. It doesn't really matter. If it's not in, it's not been done. So we also, when the 9 is put into it, 9 out of 9 times when there has been maternal indications of self-harm or hurting other people, and 9 out of 9 times an intervention's been done. So in summary, what's working well is that our providers are quite attuned to the importance of depression, but by having a clinician-only model, we've been rather failing miserably about doing the second part, which is getting the 9 done, entering a score, and moving from there. We have actually just this week agreed upon a new process where we're going back to paper using the English and Spanish versions, and our nursing staff have tacitly agreed that they will administer the paper form of the 2, and if it's positive, they'll just merely turn it to the other side and have the patient fill out the 9. If that works, when we go into the room to see these moms and kids, that should be completed and will really help us facilitate the process. So anyway, that's what we've been doing. So the change we're making right now to do a better job with the screening. We also have a subcommittee that's going to be working on some different pathways about what to do. You've got the positive screen, about turning that into confirming diagnosis versus women that are having a lot of bad things environmentally, stressors that are leading to the positive PHQ-2 and 9. Anyway, it's a lot, but that's hopefully a reasonably accurate summary about where we are.
Thanks very much. I'm sorry, was that family maternity medicine or residency?
Residency. Family Family
Residency.
Medicine is a new startup under the grant, and
Okay.
that is a faculty-only practice, and I can't speak for it right now. But the residency, I'm speaking for the 2 residency practices there.
Okay. At Mid-Hudson, the majority of the offices are doing the PHQ-2 on paper. There's a handout that we have with the screening questions all on them. And then if the PHQ-2 is positive, whoever's rooming the patient is supposed to give them a PHQ-9 to fill out for the provider to review with them. At some of the offices, that is working very well. At others, it's not. At some of the offices, they're not handing out the initial paper, and then we're having the same issue as Lancaster, that the provider is doing a verbal screening with them, and the PHQ-9 is not recorded very accurately. But we are working on solidifying the workflow of it being handed out by the front desk and everyone following the same workflow at all of the offices. So. Is there anyone on from MAHEC? How about from New Hanover?
Yeah, I'm here. Naomi Fox. So we're fairly new in collecting and entering into REDCap, so I think that's why our numbers are so low. But our PHQ-2 and PHQ-9 is completely done on our electronic medical record on Epic. And we are still trialing as to who is best suited to do it. So it depends on the resident or faculty and what they discuss with their MA or LPN at the beginning. We do huddles at the beginning of our clinic days. I've trialed it both ways, and anecdotally, yeah, I think that what works best is when the MA does the PHQ-2, and in our form that comes up on Epic, if the PHQ-2 is positive, it automatically goes to the PHQ-9, and then the MA will bring that to the provider's attention to follow up on during the visit. And that's usually what's worked well for us. But the MAs and LPNs are pretty comfortable doing the PHQ-2 because they've been doing it on all of our patients in the practice. But there's times when if other parts of the ICC, we call it the maternal screen on our Epic flow sheet, if it's positive and, if there's other small children in the room and if the visit is getting kind of busy, then sometimes they're unable to complete that. But usually they just let us know before we go into the room.
Thank you. Is anyone from...
I just had a question about that process. So it sounds like the provider then decides, how they want the screen to go. Is there discussion that in the future you'll have a more streamlined process that everybody follows, or is it going to continue to be kind of at the provider's discretion as you continue to do this?
Absolutely. We want it to be streamlined in the future. But we feel like, so our flow sheet on Epic didn't go live, usable until October. maybe like the middle to end. And so, and we also had staff turnover. We're currently still hiring for a nurse coordinator. And so the idea is that when our staff is in a stable, you know, in the next month or two, that we will go forward with a standardized process. But right now, I think what happens is that we do it different ways, and then we talk about it, like, you know, at a staff meeting or huddle, like later on, to see like what's working well, and then we'll say, okay, well this week everybody's going to do it this way, and then we'll meet back. So I think that probably in the future it's going to be that the MAs and the LPNs do the PHQ2, and then they leave up the maternal screen on the computer when the provider goes in, or they alert them that it's, you know, high or positive, and then the physician will move forward with doing the full PHQ9. And then once the PHQ9 is positive, it like automatically populates like which interventions you're doing, whether you're scheduling an appointment that day, what their risk is. And we have different flow sheets as to whether or not they're a patient of ours, or if their primary care provider is not us. So it's sort of like I don't want to say automatic, but it guides you so that the correct interventions are documented and we can put them into red caps appropriately. Does that make sense?
No, it makes perfect sense. Definitely. Thank you.
Okay. Mm-hmm.
Is there anyone from University of Pennsylvania on?
Hey, it's Mario. Hello?
Hi.
Hey, Mario.
Hi, everyone. Hey. I missed the first few minutes, and so, but looking at this data that's on the slide, it is fairly consistent with what we're seeing in our practice. As someone else had mentioned, we still have a completely provider-led protocol for screening and documenting intervention for depression screening, which is a bit of a challenge, particularly as was mentioned when the provider does the counseling and then just doesn't document it in the chart. We are able to document our screening at a pretty high rate because it's embedded in the well-child visit notes for the pediatric well-child templates at the 4, 12, and 24-month intervals that we use for screening and interconsumption care. And so that is automatic now. We are running a report in these last few months since we've introduced data elements, which will allow us to capture that information a little more easily. But the screening is documented there. EPIC allows the ability to keep essentially a screening survey result, but our current workflow, the PHQ2 does not flow into that flow sheet, and the PHQ9 is rarely used in this context. It's used in the providers use it in other elements for documenting PHQ9, and we've used it in prenatal care, but we don't flow the PHQ2 from the child's chart into a PHQ9 worksheet in EPIC, and so that would either have to be documented manually, or if it's a presumed depression, or there's an intervention or counseling that is chart extracted if it's documented, and so that explains a little bit less of the intervention rate for that subgroup of folks. But so those are some challenges that we'll be looking to address.
Thanks, Mario. When did you guys go live with embedding the template into your, I think you said 4, 12, 24-month visits?
That has been, the template itself has been embedded for at least a year, maybe 18 months. Recently, we were able to change we just had, what we had is a prompt to do ICC in those visits, and they were open-ended questions that asked the provider essentially to delete the stars and write something in. Of course, they could delete the whole thing if they wanted, but most didn't. Now, the most recent change is, I think, right around the time of the FMEC meeting, we were doing this, and if it started right before, right after. But the data is smart elements, meaning that you can toggle. There's a yes, no option answer that uses logic. So it asks the provider to check if mom is present today, and if it checks yes, then it asks about the 4 ICC questions. And if they say yes to any of those, then it prompts the next, the screening question. So if you talked about contraception, or if she's using contraception, then you pick among, the choices that pop up. So it's fairly straightforward, and for the provider, in other words, they can kind of F2 and kind of click through those things without having to type very much. But mostly it allows us to capture that data in a searchable way in the back end, which we haven't done until this week. Actually, we just, we're preparing it so that we have some accurate data for the upcoming April meeting. So that part is relatively recent.
Mario, question. Steve here. What explanation do you have for the markedly high screening, the PHQ positive screen result compared to everybody else in the network? And I mean, I have that concern about the difference between what we have here at Lancaster and most of the other network at 3 to 4%, but you're at around 60%. So can you comment about just that startling incidence of high positive responses PHQ-2?
I think that needs to be clarified a little bit. I do have some concerns about that as well. We certainly have a higher than average prevalence of depression in our community in West Philadelphia compared to some of the other sites. It shouldn't be 67% or whatever it is. However, I have a concern that if I would have to look at the data and kind of follow some of it through, but if, for instance, if the PHQ-2 is negative, but somebody documents that they provided, counseling about, stress management or depression or referral to counseling, even with a negative screen, I wonder how that gets converted or coded, both, in the way that we upload the data and then on the back end in REDCap. And I think that if there's something, maybe Amy can answer this, if there's something documented for an intervention, does that automatically flip the PHQ-2 to a positive screen?
Yes, it does. And we were wondering if that's where part of the issue is. So if the PHQ-2 is negative or blank, but there's a response for an intervention was done, it changes the PHQ-2 response to positive.
Yeah. And so, I think that could be, there could be a component of that is not unique to Penn, but maybe happens at other sites as well. And that could be both a, the kind of data, writing type of error, and it could be a little bit of a provider error too, which is why are you documenting counseling for depression if you didn't either use a validated screening instrument or if the screening instrument itself is negative. So I'm not sure. I think that would probably need to, I can talk with Sam about it at our meeting this week and try to figure out what his perspective of it is, and then I think also trying to maybe take a case example from our own data and try to see, what is being captured as, like if that is in fact happening, if somebody has a negative screen and then writes something about, counseling or coaching for mom, and then that gets coded as a positive intervention. Because technically, really, the intervention denominator should be of those that screen positive. And if you're doing interventions for moms that screen negative or that, I guess, or weren't screened. That's extra work, but not really what the kind of the spirit of what's going on. So I think that could be an issue and why the data looks funky, maybe for our end and also for the folks that are on the other end of that extreme.
So it sounds like the new build that you have you built that into the depression screening as well? So like you said, if mom is present, it asks the other 4 questions. Will it only
That's
ask
right.
the intervention questions if they have a positive PHQ-2?
I can explore that. When you move on, let me pull up a test patient and see if it does. I'll have to go through and see if that's what happens. I believe that if the screen is positive, then it prompts for the intervention. But I actually have to run through it.
Great. So, Mario, this is something that we can also talk a little bit on the UPenn site update that is scheduled for next Wednesday. And we can pull the data out of REDCap raw. These data quality rules that we developed are only used when we run the R reports. And Mike, you can speak to this. I see that you're on the webinar as well. And so we can certainly take a look at what it would look like raw versus what it looks like when we have the R report. And if there's any way you could get Sam to join that call next week, that might be really useful. Or maybe you can speak with him ahead of time just to clarify some of this. So that moving forward, it's probably a little bit more representative of your population.
Yeah, great. I think he plans to be there as well.
Great.
I forget who's next on the list. Is anybody on from Rochester? Or McKeesport?
Here, this is Jim Nabrowski. Hey, at our office, we have our MAs and nurses who room the patients actually start the PHQ-2 screen, and they the 2Q depression screen, and they put it on they'll make a little note on the rooming form. But when I talk to the residents too, they don't rely solely on that before they document in the EPIC chart. They actually will re-ask the patient questions and kind of confirm the answers. Most of the time they said it lines up, but then they put it into the chart themselves. There was a concern about RMAs asking because it seemed like they were asking in the hallway prior to being roomed as sort of an aside and almost suggestively saying, "You're not depressed, are you?" Rather than ask the questions as they're written. So the residents are actually doing it though as the questions are written to document the depression screen. We are using EPIC for that, and most of the residents are using an ICC smart phrase that, like Mario was saying, it kind of the first question is mother present at today's visit, and then if she says yes, the depression screen opens up for the first and second question. As far as our data goes on that, just the report that you had sent me in February on 2/21, it looks like some of the numbers are slightly different from what I'm seeing on the IMEET presentation. Can you hear me?
Yeah, I can hear you. Are the numbers better or worse? No, just kidding.
They're not like dramatically different, but the risk screen I see 624 versus 635, and then.
So there's a small chance that more data was entered into McKeesport since this report was sent to Amy.
Okay.
So if you're seeing similar numbers, it's just off. It's probably because more data has been entered since the report was run. The report that was used to make these slides was run.
Okay. All right. So either way, I mean, what I'm seeing mostly, though, is we have about a 7% positive response rate on the depression screen. And then as far as getting to the PHQ-9, we had 60% of our patients were actually asked, and it looks like 40% were not even asked their PHQ-9. And so, we're seeing of our positive responses to the elevated PHQ, 15 of 44 were actually, of the screen that were positive, were yes responses. So we're probably missing out, and then there's some opportunity to improve on the patients that we're not asking. So, and then of the patients where the risk was present, 13 of them did have an intervention. We did not document an intervention in 2 of them. But we were, there's some things that just need follow-up. So kind of where our data is at this point. Any questions?
No, thank you. Is anyone on from Shady Side?
Hey, it's Lisa. I tried so hard to finish my rounds and be on from the beginning, so I've just been on for like 10 minutes, and so I apologize. I know how hard you worked on this talking me. I will look at the video and catch up. I just couldn't finish all my rounds. I apologize. So it sounds like we're just presenting our process. Is that how I sounds like?
Yeah, can you see the discussion slides?
Now I can, yes.
Okay.
Let's see, who is screening, how are sites administering, and documentation expectations. Okay. So at Shady Side, so no one has presented for us yet?
No, Cleo is on the line as well. So if Cleo wants to chime in related to the UPMC depression section, that's fine as well.
Okay, yeah, I thought she was going to present. That was like our plan, but I'm happy to do it. So we have a process where our nurses, when the patient comes to our office, a sticker goes, we are almost paperless now, but we still have one piece of paper where the vital signs go on a clipboard, and on that goes a sticker that reminds the RNs to do a smoking screen and a 2Q screen, and the 2Q is actually written out because we've had some issues with it not being asked consistently the way it's supposed to. And so the nurse goes ahead and does the 2Q. If a 2Q is positive, I'm sorry, we don't do a PHQ2, we do a 2QDS. So it's a yes, no, and if either are positive or both are positive, they hand the patient the PHQ9. And then the PHQ9 is reviewed by the physician and documented in baby's chart. So that's our process, who is screening. And then the next slide that you had up was our numbers that I saw a minute ago. And so we now, we've been doing, this is all just phase 2 data for us. And we've had this same process for a long time. The only thing that we tweaked was that instead of just writing literally number 1, number 2 on the 2 questions, we wrote out what the 2 question screen is so that the nurses would ask it. And we still have a very low rate of 4.4. So we think that is underestimating, just like Penn feels that theirs is clearly overestimating, ours is underestimating. So Cleo has done extensive chart reviews and is now currently, I don't want to speak for her, but looking into shadowing and other processes here at Shady Side to figure out why our rate is so low, because we also have a very, very high depression rate. Certainly they're the same moms that we've been following for many years. We know our depression rate is probably double or triple that. So we are surprised at that low number. So we are actively doing a PDSA cycle trying to figure that out, which is not an easy task with the volume of patients that we see.
Right. So this is Cleo, and I'm facilitating at Shady Side as well. I would like to add that I've had the opportunity to speak to some of the nurses, and there seems to be, and this goes across the board with our UPMC sites that there might be a little discrepancy in how we are screening. Some nurses may be asking the question verbatim, some nurses may not be. There also might be an issue with documentation, and that's something that I'm helping to re-educate staff and work with them on. So I do know that for the most part the nurses are asking the question verbatim, and we are trying to make sure that they're documenting correctly, and there might be a couple that aren't. So we're going to definitely make sure that we address that issue.
Thank you very much. Is anyone on from St. Margaret?
So this is Cleo again. So Sukanya could not be here. She was at a board review. I am doing some observation on her residence at the St. Margaret's site, specifically at the Lawrenceville site. So I had the opportunity to observe a first-year resident who didn't have a lot of experience with screening ICC because he didn't have very many well-child visits. So when I did go in with him, he might have screened because I was in the room with him, but at least he screened. So one thing that was brought to my attention at Lawrenceville is that the nurses there do not screen for the PHQ-2, which they do at other UPMC sites. I spoke with Sukanya about possibly adding that to the workflow because that might be beneficial to the physicians there, but that's something that we are going to have to look into the future. But during my observation, I found that this particular resident, he did not screen the PHQ-2 correctly. He did not ask the question verbatim. Now there's different attitudes toward this at St. Margaret. Some physicians don't think that they have to screen the question the way it's written, that it's about the intent. So that's also something that is an issue amongst St. Margaret's screening rates, I guess. I don't know how accurate it is because I don't know exactly how all of the physicians are asking the question. This resident did not ask the question correctly. However, I think that one of the main issues at Lawrenceville specifically is that there is a large Somali population, and there is a very big language and cultural barrier. There's also an education barrier. So for this mom and child that I observed, the child, he was very active and was very distracting to the resident. So I think that that threw him off when he was trying to screen because I think that the resident was just trying to get the well-child visit over with because the child was clearly very hyperactive and was not going to sit still, and they had shots to do and they had to get through the exam. So the ICC screen was kind of the last thing on his mind. And when he was asking the questions, when he was screening for not only depression, but for tobacco and contraception as well, the mother had a hard time understanding what he was saying because he was trying to read the question at first the way it was written, and she didn't understand it, so he had to try and ask in a way that she could understand. So I think that's a barrier at St. Margaret, and I will be doing more observations and looking more into how other residents and physicians are screening and seeing if this is a pattern.
Thanks very much. Is there anyone on from a site not on the list? I don't know who's left. Jess, do you have a list of anybody, or?
So Cindy, are you still on?
Yes, I am.
Do you want to kind of share how we're screening for depression at Hunterdon?
Well, we haven't really started ICC officially yet. Just this last week, we got the final build on the template to be able to put it into NextGen. And so it'll be going into demo this next week, and then we'll be using the template because yes, there's screening that's being done on depression, but it's not really ICC, data, and it's not in any coordinated way because we haven't pushed forward without having a template to record it. So hopefully here in the next several months, we'll have data that we can enter.
Great. Do you have thoughts on how you think the process will go? Are you thinking more provider-driven or getting the nurses involved?
We've talked about it, and we've got 2 different residency sites that we're going to pilot, and sometimes we do it different ways at both places and then kind of regroup whenever we're trying to make changes. And so we've talked about potentially having at least the PHQ-2 on paper, which the patients could the moms could fill out ahead of time, assuming they can read, whether it's English or Spanish, and then having the provider go from there depending on the answer of the PHQ-2.
And then Dr. Anderson at Williamsport, I want to share what's on there.
Sure. Can you hear me?
Little choppy.
Okay, so we're just in the process of implementing the ICC workflow. We just came up with ours, and I think our go live is either going to be the 20th or the 27th. But we have the PHQ-2 on paper that we're going to hand to the patient when they check into the office. And then if that's positive, the nurse is going to hand them the PHQ-9. And then the residents and faculty will take over from there. We have not gotten to the point, again, we're just implementing it, so we thought we'd see how our workflow goes before we try to start submitting data.
All right, is there anyone else left? I think that's a no. Does anyone have any other questions?
Let me just offer a couple quick observations. We did a 3-year randomized controlled trial here with UPenn on perinatal depression. So we got quite a bit of experience with the screening. The national rates for postpartum depression around 11 to 12%. What we learned in that 3-year period of time, that was for every positive 2 that went to a positive PHQ-9, then we had a standardized process of making the diagnosis of depression versus a lot of bad stuff in women's lives or a combination. And we found that about half of the women that had the elevated PHQ-9 met criteria for major depression using the standardized clinical inventory of depression, or this SCID tool. So I throw out that as we head down the road, we want this instrument to be sensitive. We don't want to be missing folks who have it, but just because they've got the positive 2 and an elevated 9, that indicates women in distress. But a lot of our folks are really dealing with housing and food and environmental instability that may not have major depression. So we may, as a network, continue to work on refining all of this to a point of being pretty confident in our diagnosis of depression. But I laud our group efforts right now to really do a drill down about how we're doing it and opportunities to improve the the screening process and accuracy. So anyway, those are just a few that I put on the table.
Thank you very much. Jess, did you have anything further you wanted to add or any other announcements?
No, I just want to reiterate for those of you who jumped on late that our spring meeting is going to be on Friday, April 7th in Lancaster, Pennsylvania. So if you haven't had the opportunity to look at the newsletter, the RSVP date for both the network and to reserve a room at the Eden was this Monday. So it's already, kind of past the due date. So if you have yet to do that, I highly encourage you to do that as soon as possible. In addition to that, if you have any interest in participating in scholarly activity for NAPCRG, the PBRN Conference, Practice-Based Research Network, or the annual meeting, as well as the FMEC meeting, the network does plan on submitting an abstract, and so we'd like to engage as many people who are interested, especially those who may not have had the opportunity to participate in those in the past. So feel free to send me an email. And then finally, if you have yet to do so, please schedule a site update with your network coordinator, so either me, Maha, or Cleo in the near future. We'd like to complete all of these before the April meeting. So any questions, I'm happy to answer, but other than that, I appreciate everybody's participation today, and I think just, as we continue to highlight opportunities to look at the data, it gets sites to reflect on what's going on and opportunities for improvement. So thank you for taking the time to share what's going on at your site, and I encourage you to continue to look at these processes and try to improve them so we continue to not just improve data collection, but also the care of women in our offices.
Great. Thank you very much.
Thanks, Jess.
Thanks all. Bye-bye.
Bye, guys.